Today I'm going to talk about gastroesophageal reflux disease, which is another very important medical condition for which a lot of patients comes to a physician's office and see their primary physician. Gastroesophageal reflux disease is characterized by reflux of food and acid from stomach into esophagus and throat. The prevalence of this condition is around 10 to 20% in Western population. There is a very strong relationship between gastroesophageal reflux disease and obesity. Most common symptoms reported are heartburn, regurgitation, and chest pain. But the other causes of chest pain needs to be ruled out before labeling it as a symptom of gastroesophageal reflux disease. GERD can also present as a chronic cough, as a hoarseness, or worsening of asthma or asthma-like symptoms. If you look at the picture, you will see the food pipe and the stomach. And the place where food pipe connects with stomach, there is a sphincter, we call it lower esophageal sphincter. The job of this sphincter is very important. It prevents the food to go from stomach into esophagus. Gastroesophageal reflux disease negatively affect quality of life by affecting your sleep, and then if you don't sleep well, obviously you cannot function properly next day, and there is a very high chance that you can take a day off because of the illness. So you will have bad productivity at your work. Long-term complications. If gastroesophageal reflux disease is not treated appropriately, and if you don't make changes to your lifestyle, this disease can progress to erosive esophagitis, in which patient develops ulceration in the lower esophageal area. Then this condition can progress to a stricture, which is narrowing of lower esophagus. If the patient continue to have reflux and they don't change their lifestyle, this disease can progress to another condition called Barrett's esophagus. In Barrett's esophagus, the inner lining of esophagus changes from a normal epithelium or normal lining to an abnormal form of epithelium, which can lead to esophageal cancer. So basically, Barrett's esophagus is a kind of precancerous condition, and this is one of the reasons why a primary care physician refers their patient to gastroenterologist for endoscopy. So what triggers gastroesophageal reflux disease? So number one, it is your lifestyle. Smoking, the number one cause of having reflux. Obesity, your eating habits. If you eat too much food, if you don't eat on time, if you're lying flat shortly after your meal. There are certain kinds of food and beverages which can also lead to gastroesophageal reflux disease, and they are alcohol, Coca-Cola, Pepsi, all the drinks with caffeine, fatty food, fried food, chocolates, peppermint. So basically, these foods, they relax lower esophageal sphincter, and that leads to reflux of acid from stomach into esophagus. There are certain medications like anticholinergics, calcium channel blockers, nitrates, progesterone, and opioids which we use for pain. So they slow gastric emptying and can lead to reflux disease. Your body position is also very important. Doing too much exercise or sitting forward most of the time can also lead to a reflux problem, and the reason is because it increases intra-abdominal pressure, and that intra-abdominal pressure can push stomach towards diaphragm and cause reflux. There are some other conditions like third trimester of pregnancy. Some patients, they have worsening of reflux symptoms, and one of the reasons is that they have progesterone, which relaxes the lower esophageal sphincter, and the other cause is baby in the uterus pushes stomach towards diaphragm and can cause reflux due to increased intra-abdominal pressure. Tight fitting clothing, that can also cause increased intra-abdominal pressure and can lead to reflux problem. And hiatal hernia, which is a very important cause, because if you have any weakening in diaphragm muscle, then your stomach slides through that opening and can lead to significant reflux. Protective mechanisms. As I showed you picture above, there are certain mechanisms which protects gastroesophageal reflux, and they are movement of esophagus, which means that there is a peristaltic movement of food pipe which prevents the acid reflux. Then there is a lower esophageal sphincter, as I showed you earlier, which also prevents reflux of acid from stomach into esophagus, and gastric emptying time. So if your stomach does not clear food content timingly, then it can also lead to reflux problem. How do we diagnose gastroesophageal reflux disease? Mostly the clinical history is very important. Patient presents with heartburn, regurgitation, chest pain, asthma-like symptoms, or chronic cough. We do start patient on medication and see the response of the treatment. If they respond well, that can also confirm our finding. Then in some cases, we have to do endoscopy, and for which we refer the patient to gastroenterologist, who puts a tube inside your food pipe and look inside and see if there is a significant reflux over there. Or or if there's any other condition like hiatal hernia or some complications. In some refractory cases or resistant cases, we may need to do pH monitoring or some other specialized testing. We do refer patient to gastroenterologist for upper GI endoscopy, and the reason why we send the patients to specialists because there are some alarming symptoms and because of the complications I mentioned above. And those alarming symptoms are dysphagia, which means if the patient is complaining of difficulty swallowing, or if the patient has any vomiting of blood, or if the patient has melena, which means black stools and it shows sign of any ulceration, or unintentional weight loss, because these alarming symptoms are signs and symptoms of underlying malignancy or complication. And if someone has prolonged history of having gastroesophageal reflux disease, we definitely send them to specialists to make sure that these patients does not have erosive esophagitis or underlying stricture or Barrett's esophagus or any sort of malignancy. So upper endoscopy is very important for this group of patients to make sure that they are not developing any complication. So how to manage gastroesophageal reflux disease? So number one thing is lifestyle changes. Your weight is the most important thing. As I mentioned earlier that there is a very strong relationship between gastroesophageal reflux disease and obesity, so weight loss is very important. Then your body positioning is very important. You should be sitting straight while doing your work instead of reclining or sitting forward. At night when you sleep, you need to keep head end of the bed at least 6 inches above the ground. Do your regular exercise. Eat on time, at least 2 to 3 hours before going to bed. In dietary modification, stop smoking, stop alcohol, avoid spicy food, avoid chocolates, avoid caffeinated drinks like coffee, tea, sodas, and if possible, avoid citrus fruits. And again, stop smoking if you do smoke. In the medical management, there are a lot of medication in the market. In the past, we used to use H2 blockers, but now we use proton pump inhibitors. In some cases, we use prokinetic agents, but they have a lot of side effects. So we try to avoid prokinetic agents, which improves motility of esophagus in patients in which the esophagus does not move appropriately. And one of the condition is diabetic gastroparesis. In severe cases, in refractory cases, when there is no improvement, surgical management can be performed, and especially in very obese patients where weight loss is very important, these patients can go for lap fundoplication or bariatric surgery. So the important message for today is that eat on time, don't eat too much, and eat at least 2 to 3 hours before going to bed. Stop smoking if you do, stop alcohol if you do your regular exercise, and reduce your stress because stress can also make this condition worse. Thank you so much.